After this slideshow, the listener should understand the epidemiology and current classification system for germ cell tumors, be able to identify the steps and tools necessary in the diagnosis of germ cell tumors, be able to define the role of neurosurgical intervention in the diagnosis and treatment of germ cell tumors, and understand the adjuvant therapy options for germinomas and non-germinomatous germ cell tumors. The current classification system divides germ cell tumors into two large groups, germinoma and non-germinomatous germ cell tumor. The second group includes embryonal carcinoma, yolk sac tumor, choriocarcinoma, mature and immature teratoma, and mixed germ cell tumor. The incidence of intracranial germ cell tumors in the United States is 0.1 per 100,000 person years. There is a high male to female ratio of nearly 2 to 1. While prior evidence suggested that the East Asian population had a higher incidence of germ cell tumors than other places in the world, recent evidence suggests that East Asian and North American incidence may actually be quite similar. Taken together, approximately 90% of germ cell tumors occur before the age of 20 years. In the pediatric population, germ cell tumors account for 3 to 5% of all intracranial tumors. 40 to 60% of germ cell tumors originate in the pineal region, and 30 to 40% originate in the suprasellar region. 15% of patients present with multifocal disease. Presentation is based on anatomical location of tumor, tumor histology, and the age of the patient at the time of presentation. Suprasellar tumors can present with hypothalamic pituitary axis dysfunction, diabetes insipidus, and/or visual field deficits given the proximity to the visual apparatus. Pineal region tumors can present with raised intracranial pressure given the proximity to the cerebral aqueduct and/or Paranod syndrome given the close location to the quadrigeminal plate. Basal ganglia and/or thalamic tumors can present with seizures, hemiparesis, and dementia. Tumor histology can play a role in patient presentation. For example, beta-HCG secreting tumors can present with precocious puberty. Choriocarcinoma has a propensity to enlarge rapidly and hemorrhage, which can contribute to patient symptoms at the time of diagnosis. Location-based symptoms are more common in older children. In infancy and early childhood, children can present with raised intracranial pressure, which manifests as macrocephaly, split sutures, and bulging fontanelles. Children can also present with failure to thrive or loss of developmental milestones. Image A is a contrasted sagittal MRI of a suprasellar germinoma showing a thickened infundibulum. Image B is a contrasted sagittal image of a pineal region germinoma. Image C is an axial CT post-contrast of a tumor with combined suprasellar and pineal region involvement and extensive ventricular metastases. MRI of the complete neural axis serves as the cornerstone in the diagnosis of germ cell tumors. CT can be helpful for assessing density, calcification, and/or hemorrhage. Serum and CSF analysis is also critical in diagnosis. Tumor markers should be obtained from the blood and CSF when possible. Here we see a chart showing the patterns of tumor marker production. Of note, choriocarcinoma tends to secrete a high level of beta-HCG, and yolk sac tumors tend to secrete a high level of alpha-fetoprotein. A complete hypothalamic pituitary axis hormone panel, as well as formal ophthalmic evaluation, are also necessary. The role of surgery is determined by the ability to make diagnosis without tissue, the underlying histologic diagnosis, and/or the tumor location. Surgery becomes necessary if radiographic and tumor marker studies cannot make a final diagnosis. Cytoreduction is necessary based on the size and/or location of the tumor. A complete resection is necessary based on histology, and/or the treatment of obstructive hydrocephalus is needed. If hydrocephalus is present, it needs to be treated surgically. This can be achieved through ventricular peritoneal shunting or endoscopic cleared ventriculostomy. If a tissue diagnosis is necessary, this can be done via stereotactic, endoscopic, or open biopsy options. All biopsy carries a risk of sampling error, albeit low. There are a few considerations in terms of cytoreduction and/or surgical resection. Germinomas are extremely responsive to radiation therapy. There is no role for surgical debulking, as there is no proven survival benefit with surgery. On the other hand, for mature teratoma without malignant elements, resection is curative. These tumors respond poorly to other adjuvant therapies. For non-germinomatous germ cell tumors, there's often a role for second-look surgery. Neoadjuvant therapies can be used to shrink the tumor, decrease vascularity, diminish malignant components, and then can be followed by surgery for the residual component of the tumor. Radiation therapy is the mainstay of treatment for germinomas. Dose and treatment volumes vary widely based on study protocol. It remains controversial which dose to administer to the primary tumor site, as well as the role of local RT, whole ventricular RT, whole brain RT, and/or craniospinal irradiation. Multiple studies examine the value of chemotherapy and reduced dose and/or volume of RT, and these are further elucidated in the chapter. It has also been examined the role of chemotherapy alone, but currently results are inferior to those with RT alone or RT and chemo in combination. Here we see a coronal enhanced MRI of a germinoma at diagnosis on the left and 1 week after the beginning of RT on the right. Note the marked decrease in the size of the tumor after a short amount of time. Long-term survival rate is historically quite poor with non-germinomatous germ cell tumors. Radiation therapy is a critical component of treatment, yet unlike germinomas, it is not likely to achieve tumor control alone. Like germinomas, chemotherapy has not eliminated the need for radiation. Chemo and RT are necessary for optimal outcomes, yet it is to be determined if chemo can allow for RT dose reduction and/or modification. The chapter further discusses current studies exploring adjuvant therapy options for non-germinomatous germ cell tumors. Here we see a non-germinomatous germ cell tumor admixed with teratomatous components. In A, the initial tumor appearance is shown. Following biopsy diagnosis, the patient was treated with chemotherapy followed by second-look resection. Craniospinal irradiation was then administered. In B, a small focus of residual tumor was treated with a stereotactic radiosurgical boost and has remained stable with 6 years of follow-up. While teratoma is considered a subset of the non-germinomatous germ cell tumor classification type, this tumor itself deserves special consideration. If no malignant component to the teratoma, surgery is curative. Adjuvant therapy is required if resection specimen has malignant elements. In summary, intracranial germ cell tumors are rare CNS tumors largely occurring in the pediatric population. Intracranial germ cell tumors most commonly occur in the suprasellar and/or pineal regions. The WHO recognizes 6 histologic subtypes of germ cell tumors, including germinoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma, teratoma, and mixed germ cell tumor. Neuroimaging and the measurement of CSF and serum markers are critical for diagnosis. Neurosurgery is often indicated in the diagnosis and/or management of hydrocephalus. The role of surgical resection is largely histology dependent. Germinomas are primarily treated with radiation therapy, with or without chemotherapy, and carry a better prognosis than non-germinomatous germ cell tumors. Non-germinomatous germ cell tumors are treated with a combination of RT and chemotherapeutic approaches and, in certain instances, surgical resection. Mature teratomas can be cured with complete surgical resection.